So, ma'am, we are live now. Shall we start? So, very good evening, respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I, Vasist Mehta, welcome you all for the COR Connect live webinar. Today, we have two eminent speakers from Patna, Bihar. So, let us begin our session with two different interesting topics. So, to begin with, we have first eminent speaker, Dr. Meena Samant, ma'am. Ma'am is a chairperson, Clinical Research Committee, FOXY. She will be speaking upon recurrent pregnancy loss. Ma'am is senior consultant and HOD Department of OBGY, Kurji Holy Family Hospital, Patna, Bihar. She is chairperson, FOXY Clinical Research Committee. She is secretary journal, ISOPOG. She is Vice President, Patna OBGY Society, Secretary, Patna OBGY Society from 2017 to 19, Kamini Rao, Oration 2005, Organizing Secretary, Yuva Foxy 2011, Organizing Secretary, Boxcon 2018, DNB teacher. She has published many papers in reputed journals and chapters in books. So, Madam, we welcome you in the COR Connect live webinar. And over to you, ma'am. Thank you so much.
Thank you. And there has been a little change in the program, and I'm going to be the first speaker. So let me share my screen. So I hope my slides are visible.
Yes, ma'am. It is clearly visible.
Okay. So the topic that I'm going to talk on today is recurrent pregnancy loss. It's kind of an update. I know it's a very, very sad situation for the patient concerned, and of course, quite challenging for the treating physician as well. So pregnancy loss, there's some disturbance. So a pregnancy loss or the miscarriage is defined as spontaneous demise of a pregnancy before the fetus reaches viability. And a diagnosis of recurrent pregnancy loss could be considered after 2 or more pregnancy losses as per ESHRE 2018 guidelines, 3 or more first trimester miscarriages as per our COG. Then, of course, it could be a primary one or secondary as defined by ESHRE. And incidence of recurrent pregnancy loss is approximately 1 to 2% of all women. And about 2/3 repeated miscarriage. After 2 or 3 repeated miscarriage, we would be thinking a thorough physical examination and testing. That's what's recommended. Now, what is the scenario in India, our own country? There have been very few studies on this, but one by Patki et al. Says the spontaneous miscarriage rate in our country as against others is much higher, 10% versus 32%. And in yet another paper, it says prevalence of recurrent miscarriage is 7.46%. Again, we can see that it is much higher than what is defined or the figures given in Western literature. So what I would be taking you through is the review of the types of recurrent pregnancy losses, describe the etiology, and explain the investigations performed for recurrent pregnancy loss, and outline the importance of improving coordination among interprofessional team to enhance care of patients and their families affected by recurrent pregnancy loss, and see what we have to offer to them. So as per types of RPL is concerned, we have primary ones who've never had a live birth, and a secondary one, women who've had a previous live birth and then go on to have miscarriages. So etiology could be, could be defined as a genetic cause, anatomic, endocrine, antiphospholipid syndromes, immunological, environmental factors, and yet 50% of the RPL are unexplained ones. So just let's see. So as we can see, 40 to 50 are unexplained, which also includes the thrombophilias. 2 to 3 are genetic, 10 to 15 could be anatomical, 20 autoimmune, 70 to 20 are endocrine factors. Then we also have very few infections here. When we think of genetics, aneuploidy is the most common cause, which could be balanced, reciprocal, and Robertsonian translocations responsible for recurrent pregnancy losses. So balanced translocations are most common, with 60% being reciprocal, 40 are Robertsonians, and in 20 to 50% there is a risk of pregnancy loss in these cases. So if we look at it in a positive way, around 50 to 75% of these can still go on to eventually have a normal offspring. That's how a genetic counseling comes into play. Let's look at the anatomical causes. Now, estimated prevalence, I said, is around 20%. Congenital Mullerian tract anomalies like the septate, unicornuate, bicornuate, didelphic, and arcuate uteri could be there. And the acquired uterine anomalies like fibroids, polyps, and Asherman syndromes could also lead to RPL. As far as endocrine causes are concerned, we have diabetes, thyroid dysfunctions, hyperprolactinemias, polycystic ovarian syndromes, and the luteal phase defect. And immunology also has some role to play. There is alteration of T helper cell. There is a poor outcome with T helper 1 dominant environment, and of course, progesterone, also because it is also involved in immunological modulations. Now, antiphospholipid is very important, accounts for 8 to 42% cases of RPL, and it should be a part of the initial workup in patients with RPL. But what about the inherited thrombophilias? Inherited thrombophilia in a patient with family history of thrombophilia or personal history of VTE, only then it could be a part of the workup. And these thrombophilias would include factor 5 laden mutations, the prothrombin gene, that is PTG20, 2010A mutations, protein C and protein S deficiencies, the endothrombin 3 deficiency, and methyl tetrahydrofolate mutations. So those with a history of VTE is that we are talking about. And yet we all know for sure that the female age is so important. In the age group of 20 to 24, the spontaneous miscarriage rate is 11%, while when we reach an age of 40 to 44, the spontaneous miscarriage would be 51. So naturally, they would, be responsible for RPL to a greater degree. The risk of having is strongly influenced by the female age. But then there are certain miscellaneous causes as well. The obesity is, especially now, it's becoming more and more prevalent, so it makes an important cause. The smoking, excessive caffeine consumption of more than 300 milligrams per day, or that is equivalent to 2 cups in a day, would be not very good. And excessive alcohol intake, cocaine, and the psychological factor. Even grief and depression, hopelessness, all these, can have been implicated in causing pregnancy losses. So the other miscellaneous we could think of is the male factor trend towards repeated miscarriages with abnormal sperm, that is less than 4% normal forms, and sperm chromosomal aneuploidy. So here we go for ICSI. Paternal HLA sharing is not a risk factor. Advanced paternal age may be a risk factor for miscarriage at a more advanced age than the females. And infections though they may be, a cause for IUD and this thing, but not for recurrent miscarriages, because they don't stay there as options. So then again, there are the unexplained ones where no apparent causative factor is identified. Most miscarriages are sporadic and are thought to result from genetic causes that are greatly influenced by the maternal age. And in patients with unexplained RPL, the chance of future successful pregnancy can exceed 50 to 60% depending on the age and the parity of the woman. So let's see what we have to do when such a patient comes to us. What is the workup? So what about the antiphospholipid? This is very non-controversial. ESHRE recommends screening for antiphospholipid antibodies, that is lupus anticoagulants, anticardiolipid antibodies, both IgG and IgM, and beta-2 microglobin glycoprotein 1 antibodies. They can be considered up to 2 pregnancy losses. So this is something recommended, and MRCOG says after 3 or more losses, which are less than 10 weeks, 1 or more morphologically normal fetus after 10 weeks, 1 or more preterm births before 34 weeks owing to placental disease. So here we have to go for a blood test. So mechanism by which the antiphospholipid antibodies cause pregnancy morbidity include inhibition of trophoblastic function and differentiation, activation of complement pathways at the maternal and fetal interface, resulting in a local inflammatory response, and in later pregnancy, thrombosis of the uteroplacental vasculature. Let's look at the uterine anomaly. All women with RPL should have an assessment of the uterine anatomy, preferably by 3D ultrasound, which has a high sensitivity and specificity. Sonosalpingography and hysterosalpingography can be done if tubal evaluation is also required. Then if Mullerian abnormality is diagnosed, further investigation for kidney and urinary tract evaluation should be considered, and MRI is not recommended routinely, though it can always help in some of these women, especially when obesity and all those things are there. Now, let's look at genetic factors. Medical and family history should be used to tailor diagnostic investigations in RPL. Genetic analysis of pregnancy tissue is not routinely recommended, but it could be performed for explanatory purposes, because always the patient wants an answer why it happened, will it happen again? And if you're doing the test for the product of conception, array-based comparative genomic hybridization is recommended based on reduced maternal contaminations. Paternal karyotype may be done after parental karyotyping may be done after individual assessment. So this again is something where we have to, where we can answer some of the questions and do it for the patients. Now looking at what ASRM says, it recommends parental karyotyping analysis as balanced, reciprocal, or Robertsonian translocation is present in 2 to 5% of RPL couples, thus could present major prognostic factors. ESHRE recommends testing only in couples at an increased risk induced evidence by prior child with congenital abnormalities, offsprings with unbalanced chromosomes, or translocations in conception. RCOG advises parental karyotypes when an unbalanced structural chromosome is found in the RPUC, and referral of the couple for genetic counseling is done. So it is for all RPL couples is simply not cost effective, and therefore overall, and there is no overall difference in the live birth rate when comparing pre-implantation genetic testing to natural conception in these cases. So that is why we have to be selective in what we are answered and what we are looking for to answer our questions. And a microarray based testing is more, answers more. So product of conception, that is cytogenetic analysis, ASRM and RCOG position or POC genetic testing for RPL are based on current standard of conventional G-band karyotype analysis. Whatever we were saying was karyotype. Now, ESHRE recommends CMA as preferred modality of that POC genetic testing because it is not limited by tissue, that is microarray based, because here you don't have to culture, so you don't get negative culture failures and false negative results by doing this. And there is also no contamination by the maternal cell is also less here. So this is preferred. And 50% of the 46XX normal reports from POC testing results from maternal cell contamination. So method to ensure correct status results are required. And also only 75% culture yield is there. So now what ESHRE recommends is CMA for the product of conception to detect balanced structural chromosomal rearrangements and low-level mosaicism. Now coming to the causes, we have thyroid screening, that is thyroid TSH and thyroid peroxidase antibodies is recommended for women with RPL, followed by T4 if previous results are abnormal. Then human leukocyte antigen, that is HLA determination and cytokine testing is not recommended in clinical practice. However, many people are doing that as a part of research. Now, there is insufficient evidence to recommend natural killer testing in either peripheral blood or endometrial tissue in women with RPL, and anti-nuclear antibodies could be considered for explanatory purposes. So here again, while thyroid we would be doing in all our cases, anti-nuclear where we think we need to give explanation to them. However, others are not routine tests. Then for male factors, sperm DNA fragmentation, meta-analysis have showed significant increase in miscarriage in patients with high DNA damage compared with those with low DNA damage. It seems reasonable to offer sperm fragmentations testing to couples with otherwise unexplained RPL. Ordering SDF could be useful and could have strengthened the decision to pursue lifestyle modifications. So whether or not we are testing, I think lifestyle modification has to be advised to all our patients. But having this test, we know we are more confident in giving explanation and also managing these patients. So what is generally not recommended? One is fasting insulin, because we want to know PCOS and all that. So fasting insulin is not recommended. And blood sugars in non-diabetic. You would know if they're diabetics or non-diabetics. So androgen testing is not routine. Prolactin testing in absence of galactoria, amenorrhea, oligomenorrhea. Then ovarian reserve testing again. Luteal phase insufficiency, LH level testing, and homocysteine plasma levels are not recommended routinely, unless of course we have a particular reason to ask for that. Now, I did mention about the chromosomal microarray. So, why this is being told, and what is it? So, till now, what ASRM workup, it tells about all those, the anatomical, the genetic, the thyroid, EPLA, those are the usual recommended, and as per the findings that would be recommending. Or some if one is going by only POC. Here the normal you would get 42 and abnormal 57. In ASRM recommend you would get 42 abnormal and 57 normal. But if you do both the routine workup as defined by the ASRM and the product of conception, chromosomal microarray, so that increases abnormal findings. So it gives you more answers. So this is one thing that one could, where it is possible to get that, because we can give more answers to a patient as to the cause as well. So here, this is a summary from various guidelines that have been compiled here. Parental karyotype, while ASRM says yes, others say not routine but conditional, where if the POC is affected, then go for that. POC cytogenetics recommended after third and subsequent miscarriage. ASRM says first you do the karyotype of the POC. Only in the setting of ongoing therapy of RPL would you like to do a parental karyotyping. So like that, even all the guidelines are not conformed in their the recommendations. So we have to use our own judgment. And of course, uterine anomaly, it's so simple to get an ultrasound done. So this one should not miss out because they're also treatable. And anti-possibility, all the societies, all the guidelines, they do recommend EPLA testing, uterine anomaly testing, while others are conditional, or they are recommended by most, but they are conditional mostly. And thyroid testing is recommended, while others we have to be little more judgmental in our approach, more selective in our approach. So briefly, we'll take a look to the treatments that we can offer to our patients. Of course, it should be started preconception, as we know that RPL is a kind of retrospective diagnosis. After they've had their miscarriages, then only we label them as RPL. So the preconception counseling in women with RPL could include general advice to consider prophylactic vitamin D supplementation. Low-dose folic acid is routinely started preconceptionally to prevent NTD, but it has not been shown to prevent pregnancy loss in unexplained RPL. Now we know, having a pregnancy loss also has a social impact. It has a significant negative life event, and the repetitive nature of RPL may intensify the grief experienced by the patient and their family members. Studies are mostly focused on women, and there is a need for studies on the emotional impact of RPL on the men, the partners. Now, clinicians and clinics should take psychosocial need of couples faced with RPL into account when offering and organizing care of these patients. Risk and health behavior modifications should begin before conception. Women should be sensitively informed that the risk of pregnancy loss is lowest in women aged 20 to 35 and rapidly increases after the age of 40. Stress is associated with RPL, but couples should be informed there is no evidence that stress is a direct cause of pregnancy loss. And also, they should be informed that smoking could have negative impact on their chances of a live birth, and therefore, cessation of smoking is recommended, and also advised to limit alcohol consumption. Striving for a healthy normal range BMI is recommended. So all couples with results of an abnormal fetal or parental karyotype should have a genetic counseling. The guideline development group recommends to base prognosis on the number of preceding pregnancy losses and the female age, because this is something fixed. We have it at hand and we can give them a good guide as to what they can expect. The couple should be informed about the limited evidence of PGD, that is pre-implantation genetic testing in couples with RPL, shows no clear benefit of treatment. For women with normal ASRM workup with a aneuploidy product of conception as sole identified cause, at least last miscarriage, counsel women about chances of future live birth child based on maternal age and normal. So we can tell them about the aneuploidy, and from that we can give them a better this thing. 25% of women with product of conception aneuploidy by CMA will have at least one concomitant abnormal finding on ASRM evaluation, should benefit from treatment. So it's not just if we get a abnormal POC aneuploidy, we don't have to. It's not that we would do both, because sometimes some of the genetic problems may not be contributing. There could be some other things. So we should not stop at one. because then sometimes these patients may need donor ovum or donor sperm depending on the genetic problem that has been identified. So for women with hereditary thrombophilia and a history of RPL, ESHRE suggests not to use antithrombotic prophylaxis unless in context of research. So hereditary thrombophilia, it's not for RPL, but you could give it either as a research or for preventing venous thromboembolism. And for women who fulfill the lab criteria for antiphospholipid syndrome and a history of 3 or more pregnancy losses, administration of low dose aspirin, that is 75 to 100 milligrams per day starting before conception, and a prophylactic dose of heparin, that is unfractionated heparin or low molecular weight heparin starting at the date of a positive pregnancy test is recommended. Of course, for overt hypothyroidism arising before conception or during early gestation should be treated with levothyroxine in women with RPL. And treatment with levothyroxine is recommended based on existing guidelines and possible maternal and fetal complications associated with untreated hypothyroidism. Uterine anomalies have to be addressed. Metroplasty is not recommended for bicorporeal uterus with normal cervix. Whether hysteroscopic septal resection has beneficial effect, that is improving live birth rates and decreasing miscarriage rates without doing harm, should be evaluated in the context of surgical trials with RPL and septate uterus. Surgical removal of intramural fibroids is not recommended, but of course, if they distort the uterine cavity, yes, they have to be removed. Now, immunotherapy, lymphocyte immunization therapy should not be used as treatment for unexplained RPL. IV immunoglobulin is not recommended as it has no significant effect and there may be serious adverse effects as well. And glucocorticoids are not recommended. Then unexplained RPL, heparin or low dose aspirin is not recommended as there is evidence that they do not improve the live birth. In women with unexplained RPL, there is insufficient evidence to recommend intralipid therapy and so on. So in unexplained, of course, while you're doing a tender loving care is most important. A bit about the second trimester losses. Women with history of second trimester losses and suspected cervical weakness should be offered serial cervical sonographic surveillance. Systematic review and meta-analysis reaffirms that vaginal progesterone reduces the risk of preterm birth and neonatal morbidity and mortality in women with a singleton gestation and a mid-trimester a cervical length less than 25. So they can perform transvaginal screening 18 to 24 weeks of gestation in women with singleton and offer vaginal progesterone with those who have a cervical length of less than 25 millimeters or a cervical cerclage. Of course, when you're doing a cervical length assessment, you should do it by transvaginal sonogram after 16 weeks. Before 14 weeks, it has limited value. It should be serially monitored every 2 to 3 weeks until 24 weeks. And these are the normal cutoffs. And while taking the cervical length, one should, DVS I said is better and should take three lengths and use the shortest one to define the length of the cervix, because there could be a some contraction passing which can cause a false lengthening. Okay, so a bit about the cervical cerclage in women with singleton pregnancy and history of recurrent second trimester pregnancy loss attributable to cervical weakness. A cerclage could be considered, and there is no evidence that this treatment increases perinatal survival as per the ESHRE guideline. But in women with singleton pregnancy, history of 1 second trimester loss attributable to cervical factors, And ultrasound showing less than 25, we go for cerclage. There are various studies. And these are the Shirodkar sutures, which is used less and less, going more for McDonald. And sometimes one may have to go for Strom sutures if the length is very small, cannot hold the cervix, reach higher. And there is also a role for transabdominal if the vaginal ones have failed and it's a very short cervix, which can be done both by laparoscopy and an open. And we'll not talk about rescue because we talk about recurrent pregnancy loss. And just because it's something new, the Arabin pessary, which is under trial, and it one can do away with the cerclages and just put this pessary, which can hold the cervix. There is some role for progesterone as well, especially in threatened and recurrent miscarriages. And vaginal progesterone does not, various kinds of studies and the results, but those with at a risk of this thing, and second trimester shortening of cerclage, we would give progesterone, shortening of cervix. There's a good evidence that 400 milligram twice daily micronized vaginal progesterone increases the number of live births in women with early pregnancy, bleeding, and previous miscarriage. That according to the study, there was no evidence of benefit for any other preparations or doses of progesterone, so committee made research recommendations. And it should be started after confirmation of intrauterine pregnancy on scan until 16 weeks of pregnancy. And both micronized progesterone and according to ESHRE, oral dydrogesterone has also shown benefit. These are some of the studies are there. So I think with that, I come to the end of my thing, where how to work up the recurrent pregnancy loss and what therapy we can offer to our patients when we have to go for the PGDs. So thank you all for your patient listening, and thank you, Alka ma'am and Corona, for giving me the opportunity to share my thoughts.
Thank you, Meena. Very nice.
Thank you so much, ma'am, for such a insightful presentation. Before we moving ahead, let me tell you, we have total 189 viewers till now. In that 130 viewers are in our coreconnect.org website, and remaining are at YouTube and Facebook live, ma'am. So thank you so much for giving us such a useful information. Now we have our second speaker, none other than Dr. Alka Pandey. She is Vice President elect Foxy, and she will be speaking upon cesarean scar niche. Madam is Associate Professor, Department of Obs and Gynae, Patna Medical College. She is Vice President elect Foxy for 2022. She is Member Governing Council ICOG. She is Chairperson Practical Obstetrics Committee Foxy for the period of 2015 to 17. National Corresponding Editor Jogi 2017 to 23. President Patna Obs and Gynae Society 2012 to 14. Joint Organizing Secretary 57th AICOG 2014 and Organizing Chairperson 24th BoxCon 2014. Welcome you, ma'am, and
Thank you.
request you to please give us your insightful information on cesarean scar niche.
Thank you so much. So I'm going to talk on cesarean section scar niche. It is also known as scar defect or isthmocele and is a known complication of cesarean delivery. it has become common due to rising cesarean section rates. Now, what is cesarean section scar niche? It is myometrial discontinuity at the cesarean section scar site with a sonographically visible indentation in the myometrium of at least 2 millimeter. The definition, etiology, presentation, diagnosis, and management of previous cesarean section scar defects. It was the topic published in Journal of Obstetrics and Gynae 2013. So here you can see the cesarean section scar niche, which is being shown in this picture. In the longitudinal plane, you can see the A is the depth, then B is the width of the isthmocele, then C is the adjacent area, and residual T is the residual myometrium. In transverse plane, E is the length of the isthmocele. So the prevalence is about 7 to 88%, and there is emerging manifestation of cesarean section scar defect in reproductive age, published in Journal of Minimal Invasive Gynecological Surgery. What is the etiopathogenesis of cesarean section scar niche? A very low incision in the cervical part of the uterus that contains mucus glands. Mucus produced at the time of wound healing may dilate the sutured edges of the myometrial tissue. Here you can see the mucus glands. Then, why do niches develop in cesarean section uterine scar? Hypothesis or etiology of niche development, human reproduction. This was published in 2015. There is improper wound suturing without including all layers of the myometrium. Here you can see this, and this is one of the etiopathogenesis of cesarean section scar niche. Then early adhesion between the myometrial wound and the anterior abdominal wall. The adhesions pull the edge of the wound, thus impairing the healing process. Impaired perfusion and hypoxia lead to less production of collagen, which leads to delayed healing of the scar. Then surgical techniques. There are certain risk factors. Surgical techniques. Very low uterine incisions. Low incision through cervical tissue contains mucus-producing glands, which might interfere negatively with the wound healing process. Then cesarean section during active labor with cervical effacement. In active labor, the stretched lower segment may specifically affect the healing property of the myometrium. This was published in Cesarean Section Scar Defects, Agreement between Transvaginal Sonographic Findings with and without Saline Contrast Enhancement, Ultrasound Obstetrics Gynae of 2010. Then patient who received a locked continuous single layer suture compared with interrupted single layer suture group showed a defect area statistically longer on ultrasound and hysteroscopic evaluation, probably due to an ischemic effect on the uterine tissue. Then multiple cesarean section scars. Repeated trauma to the ischemic wall disrupts the normal healing process and vascular perfusion may be reduced in the scar tissue. Then retroflexed uterus, increased BMI, every additional unit of body mass index increase the risk of isthmocele by 6%. Then postpartum fever and infection, history of GDM, genetic disposition, low platelet count, postpartum, high fibrinogen results in formation of larger and more stable clots that may block vessels within the myometrium and so create defects. Now, what are the clinical symptoms of this CS scar niche? That is abnormal uterine bleeding, particularly the postmenstrual spotting. Blood accumulates in the scar defect and then seeps out slowly over the days after menses. Impaired uterine contractility at scar site. Then dysmenorrhea and pelvic pain. Presence of lymphocyte infiltration and anatomical distortion or abnormal myocontracture due to continuous efforts of the uterus to empty the contents of isthmocele. Then infertility. Persistence of menstrual blood in the pouch affects the cervical mucus as well as sperm motility and implantation, probably due to an inflammatory condition. Then formation of an abscess due to collection of menstrual blood. Then risk for complication increase in IUCD placement, evacuation and embryo transfer. Then uterine rupture, scar ectopic pregnancy, morbid adhesion of placenta, that is placenta accreta, increta or percreta. Then diagnosis. Caesarean section scar defect. A prospective study on risk factor has been published in a journal by Bij D. Vate et al. So contrast enhanced ultrasonography, TVUS in women with history of caesarean section in early follicular phase. Then by sonohysterography also you can see the scar niche. Then HSG. HSG also shows the scar niche. Then MRI. You can see here the caesarean section scar defect. Then by hysteroscopy. Then laparoscopy also. Now, what is the treatment? If it is asymptomatic, no treatment is needed. Medical treatment is with oral contraceptive pills for 3 months. It has been tried in women with scar defects, and it has been found that the defect and vascularization was decreased. Now, surgical approaches can be by hysteroscopy, laparoscopy, and conventional. So the concept is you remove the scar tissue and repair the defect in 2 layers with 0 polygalactic. When you do hysteroscopy, isthmocele appears as a bulging on the anterior wall of the cervical canal. This defect can be treated with a technique called isthmoplasty. Scar diverticulum is removed and dilated vessels are fulgurated. There is risk of perforation and bladder injury if myometrial thickness at the site of defect is less than 3 mm, and it is found to be useful and successful in 85.5% of the cases. Then laparoscopically also you can see the isthmocele can be repaired. The scar tissue has to be removed, and you have to close the defect by 0 polygalactin in 2 layers. So you can see the defect before surgery and after surgery. So clinical symptoms are relieved in 85% of cases. Pregnancy rate is 71%. And how to prevent? You should reduce the number of caesarean sections. Full thickness of the uterine wall should be included in the suture so that the strength will be preserved. Then sutured muscle tissue will never regain its original strength. In contrast to fibrous tissue, the less muscle tissue cut, better are the chances of a stronger scar. The more stitching material left, the more foreign body reaction occurs, which might weaken the scar. Caesarean section scar defect is myometrial discontinuity at the scar site with a sonographically visible indentation in the myometrium of at least 2 mm. Prevalence is 7 to 88%. It may be asymptomatic or present with postmenstrual spotting, dysmenorrhea, infertility, extreme thinning of lower uterine segment during labor, scar ectopic, morbid adhesion of placenta, scar dehiscence, and uterine rupture may occur. So to summarize, caesarean section scar niche can be diagnosed by HSG, TVUS, contrast enhanced sonography, and MRI. Asymptomatic cases need no treatment. OCP has proved to be beneficial. Scar niche can be treated surgically by hysteroscopy, laparoscopy, laparotomy, and vaginally. Prevention can be done by lowering caesarean section rates. correct apposition of uterine muscular layer, and leaving behind less suturing material. Thank you so much.
Thank you so much, ma'am, for such an informative session. Corona always look forward for such kind of webinars with such interesting topics. Thank you so much, both the speakers.
Thank you very much.
Thank you, ma'am. Thank you, Meena, ma'am.